Thanks, Bobby. All right, thank you. And let's start the screen share. So, all right, just to make sure, Kara, I can see you. Just a thumbs up. Does the screen look good? Perfect, thank you. I love your visual, your look today. All right, so today, what can we talk about? So one of the things that I've learned and kind of honed in over the years is the process and the benefits of conceptualization. So really how to conceptualize anything. And so that's going to be our topic for today. I'm going to go back and just share a little bit about, so I work alongside Bobby. I'm from Case Western Reserve University at the Center for Innovative Practices. So I actually started working with families back in 2000, doing home-based family counseling in an evidence-based practice called multisystemic therapy. I've been with CIP since 2007. I focus now on family trainings, intensive home-based trainings, and all of those fun things along with ECHO. So let's talk about conceptualization. So if we were to Google search it, defining it, what is it? What does it mean? It's the action or process of forming a general notion or idea. It's also a general idea or concept of something, combining all of its characteristics or particulars. So that can kind of help us understand what really we're thinking about here. So commonly used in, so I mentioned MST. So this is really the first place that I learned how to conceptualize in the most effective manner. And it's a process. So in MST, they call them fit circles for any MSTers on here. And so I still, I grabbed onto that notion and that problem solving tool, and I've held on to it for over 20 years. One of my teams, IHBT teams, is FBIT at Nationwide Children's Hospital. We regularly use them. And this process of conceptualization is also regularly used in other areas besides clinical or behavioral health. They use them in research, they use them in business, and other areas as well. So as I shared, I've really used them for over 20 years, MST, IHBT, but I also use them in pretty much every area. So families that I work with clinicians that I've supervised, teams that I work with, supervision, consultation, research, but also personally. And so that was really the shift that I acknowledged, like, yep, this is meaningful, helpful for me, and I'm going to keep doing this. I recognize that as I was on a drive from Canton to Akron, and there was a bit of an argument. I think we were stopped in traffic on 77. There was an argument leading to like road rage kind of stuff, and my thought immediately went to, oh, I wonder what's going on with them that would lead them to that. There could be this, there could be this, there could be this. And so that's when I was like, yep, I'm conceptualizing this issue in a multi-determined way rather than jumping to conclusions and things like that. And so that's really where I've generalized that and applied it to my personal life as well. More recently, in the beginning of this year, I'll share that, I've had some health issues. And so really this was where I started with conceptualizing all of those factors. I put this plan in place, and here we are at the end of the year, and overall my health is significantly improved because I've gone through this process myself. So we're going to focus today on clinically, how do we use this in a behavioral health manner? So tell me more. So conceptualization. So it's really a structured brainstorming exercise that we can list as many possible causes or hypotheses for something. Those contributing factors are going to be seen as driving or contributing to that main issue that we're trying to understand. We also want to get valid, reliable information from multiple perspectives. So multiple perspectives are going to be not only what I see, but also, and we're going to talk about it in regards to families, What does the youth say? What does the family caregiver say? What does the school say? What does any other provider say? So multiple perspectives. It's multi-determined. So I'm not just thinking with blinders on, but I'm opening it up. We also, of course, want to be trauma-informed, strength-focused, and display that biopsychosocial and developmental perspective. Lots of things to be mindful of. As well as we use our clinical expertise. We want to rely back on evidence-based practice and research. What does it tell us? And yes, sometimes I say we use our spidey senses. So something feels off, or it might be this. So when that happens, what we really want to do is to gather evidence for or against it. And so that might be a potential working hypothesis. All right, so what do I conceptualize? So again, we're going to focus on behavioral health for our system of care, ECHO, in regards to youth involved with multiple systems. So for example, it could look at the youth's presenting problems or reasons for referral. For example, truancy. It could also look at, for example, let's say substance use, or a second level assessment or conceptualization. So if we're looking at youth substance use, one of the driving factors that research tells us is that they tend to have contact with substance using peers. So we can also look at a second layer, conceptualization. Why do they have contact with substance using peers? If they had past treatment, I immediately want to understand why was it unsuccessful if they're working with me again. Also, why it was successful, if there's any little nuggets of success, so thinking solution focused to leverage that. And then also possibly why treatment gains didn't sustain. Maybe they closed successfully, but they didn't sustain over time, and why that is. Another thing to focus on for conceptualization, for example, it could be some type of interaction. So maybe it's family conflict, parent-child conflict. So some type of interaction. It could be interfamily and intra-system as well. So maybe it's, family to school, there's a disconnect or conflict there. So looking at something around the interactions. It could be around engagement in treatment, buy-in to certain interventions. It could be specific things around, for example, if there are, and most, I would say, these tend to be common issues that we find doing home-based working with families. So maybe there's supervision monitoring gaps. And when we look at that, a lot of times we find there's a low social support network. Barriers to co-parenting, couple discord, and also want to be mindful of any basic needs challenges. Is there anyone that wants to place the youth out of the home? So remember, one of the things for IHBT, intensive home-based treatment, is we want to do our best to maintain the youth least restrictive in the home school community, things like that. So is there anyone that is not engaged in that, and why? And if there's a success, let's take a look at that. How do I conceptualize? So thinking, what do I want to know more about? What am I curious about? What will help me understand things better? Problem solve now. Different domains, youth, family, school, and peers. It should never just be one factor. It should be multi-determined. Again, the interaction. So this is the contextual part for MFT. This is our systems thinking. Barriers to treatment success. What am I missing? Are there basic needs challenges, intergenerational trauma, cultural factors? Fall back upon not only evidence-based practice, but also evidence. Like, what is the evidence? It's not just am I guessing, but what evidence do I see? Is it confirmed by multiple persons? Do I need to test any hypotheses? And then provider barriers. Those are the things that I can address and change quickly. And so I want to know, what am I doing that's helpful, not helpful? Am I successfully collaborating with everyone involved? How could I better serve the family? What would they want me to know? How can I learn from them? All right, so it's all going to start with the why. So we want to use very detailed problem or issue. language. So for example, this will give you kind of clarify, bring to light a little bit more of what we mean. So example one, so client struggles with low self-esteem at times, does not know how to manage distressing moods, becomes dysregulated often. So super wordy, a lot of things going on there. Might likely be true, right? Versus Elijah sneaks out his bedroom window at midnight on Friday and Saturday nights after parents go to bed to drink alcohol with his neighbor friend Jacob in his backyard. So very different. So one is very vague, like kind of wordy. It actually talks more about intervention than problem. And it's assuming a few different things. The other one is very much more specific and targeted with detailed information. Example number two, lack of engagement with caregiver versus mom canceled an appointment, has not replied back to my texts or phone calls for 3 days. So very different in the content of the information. I can make much more sense and do much more effective work in problem solving with the second options in both of those. So really we're asking the why, and those contributing factors are going to be the because. So thinking, right? Problem solving, that light bulb is going to go off for us. So a basic template that we want to think this in is in the middle, what's the issue we're assessing? So we gave examples of referral behavior, things like that. How are we ensuring that it's multi-determined? So we want to be culturally mindful. We also want to include those youth factors, family factors, peer factors, school factors, and community factors. And this will make more sense as we apply some specifics to it. So for example, if we take a look at family conflict. So for youth and family, conflict is reinforced, youth gets their needs met. If we look at within the youth factor or the youth domain, youth is maybe argumentative, impulsive, or problem solving. Likely the family factors are going to be several here. For example, maybe they have a trauma response. It's modeled in the parent dyad. Negative peers, it's reinforced there. In the community, it's maybe normalized or encouraged. And in the school, it's likely not addressed or youth aren't held accountable. So this is just an example of how we want to ensure that we're targeting or identifying factors in all of those different domains. So this is a more helpful conceptualization of family conflict and allows us to understand it in a broader way. So what we hopefully would not want to see is something like this. Clients truant, parents don't care, kid does it to have fun, they get picked up from school. So while all of these might have some truth here, it doesn't really give me much information. So I can't really do much with it. A better conceptualization. Wanna skipping chem class Thursday, Friday every week for last 3 weeks. And I'm just gonna pop these factors up here so that you can see. So we have the lack of communication. She's not being marked absent. She really sees no value. Parents assume everything's okay. There's really low homeschool communication and link, no meaningful contingencies, and her boyfriend is, picking her up. So this is a better fit. So this is a really helpful example of the more information that we can add, the more detail, the better able we are to understand it, the more effective our interventions will be to target it for change. So we do this great conceptualization, and then what? So after conceptualization, ideally we'd like to move to prioritization. So thinking, with all of these factors, what would give me the most bang for my buck? If I target 1 or 2 things today, this week, what can I impact change around? If I'm working with the family, I want to know what's important to them. What are their priorities? What do they need to change right now to stay engaged or to find hope or to keep moving forward? what does the research tell me to target? What do I know? What things need to be addressed first? Are there any practical barriers? So for example, basic needs or access to resources, skills, things like that. And then most specifically, skills that are missing. So those priority factors are going to be our focused interventions for change. And then we're going to continue that same process until progress is made. So it's kind of a never-ending loop. So for example, if we go back to Juana's conceptualization, this is what it looked like to refresh your memory. And so as best I could, the highlighted or the bolded ones in white factors are the ones that we would choose to prioritize. So they're the ones that we could likely impact change around, get the most bang for our buck, or get a quick turnaround with. So, so there's certain reasons why we would target those, with engagement from home and school. And so choosing to target those, this is what the plan could look like. So again, our priority factors. Teacher's not marking her absent. Parents don't know she's skipping, so there's no communication from school to home. Parents just assume everything's okay. She's there when they get home, and there's really no meaningful contingencies. All right, so those lead us to our interventions for change. So that leads us to the chemistry teacher will mark her absent. Somebody from the school will inform the parents daily if she's skipping or leaving class. There will be a family meeting or check-in daily, sharing the highs and lows. Maybe they have dinner together, whatever we want, want to identify it as. And there's some meaningful reward or consequent based on that daily report. So what's earned or lost based on that. Possibly other areas to assess for. So we also, anytime we do an intervention, we want to be cautious of what could be a loophole or a barrier to that success. So we want to assess, does Juana need support at school? Does she need a positive peer support, a teacher support, somebody to help with monitoring or shifting that? Does she need refusal skills to the boyfriend? Or can we, or do we need to include boyfriend to get his buy-in to linking him to her college goal or sharing other time together? All right, and we will wrap this up here shortly. So on the flip side, I also mentioned we can do this when we have successes. So one of the times that we do this is hopefully at the end of treatment. So an example of, let's say, Benny and family treatment success, and all of the things that we want to highlight they have done well and that we want to reinforce for them sustaining over time. And these things would be included in their maintenance plan. So what's going well and how do we keep it going? And lastly, so a fun one, why is system of care ECHO for youth involved with multiple systems effective? So we have our hardworking team presenters every week, our hub experts that are just so knowledgeable, the learning community that shows up every week, our spokes added guidance and knowledge, didactics, hopefully are interesting and helpful for the population we serve. Carrie and Jamie always have a great icebreaker every week. Today being unicorn zombies. And valuable recommendations are given to our most challenging cases presented. So, so all of us can learn from that. And lastly, that there is that evaluation process which gathers feedback so that we or they can learn how to improve it. All right, and so just to challenge everyone, what will your conceptualization be on? whether it be clinical that you're working maybe with a youth and family, or even for yourself, and thinking of the end of the year and thinking of new horizons for the next year, could be a good time to think of what are some issues that you would like to change. That conceptualization process can be a good first step to target change for the next year. And there is my contact information if anyone needs to reach out for anything. And with that, we are done. Thank you so much.